Okay, so pelvic fracture. Again, we normally go for X-ray or CT. These days, CT is standard because we can get a 3D view. The MRI is generally reserved if we can't see anything obviously, or if we're suspecting more of an insufficiency type fracture. If we're suspecting ligamentous injury as well as the other time that we do it. So it's particularly useful in our elderly osteoporotic patients where we're suspecting insufficiency as an issue. If we have a person who initially starts off with normal imaging, but again, the clinical course that the person is going or the signs that they're manifesting isn't answered by the CT scan, then an MRI scan is often requested. And if we want to look at the sacroiliac joints or the integrity of the pelvic ring, we sometimes order an MRI. So with pelvic insufficiency fractures, we often get them in very specific areas. So I've given you a summary of where we get them. So just adjacent to the sacroiliac joint, in the pubic rami, different places in the pubic rami, so superior pubic rami, just adjacent to the symphysis. We get it here in the actual sort of more of a vertical one in the sacrum itself. We get one in the supraacetabular area, and then on the iliac crest itself. So this is where we sort of, these are the main areas when you're looking at a scan or you're looking at any kind of imaging, you just check through these particular zones because these are very, very common zones to be injured. And you can see this is showing again on the fluid-weighted sequences. So this is your stir and this is your fat-suppressed, fat-saturated T2. You get the bright signals that come through there. So this is an axial scan. There's your iliac crests going out the side. This is your sacrum on the front. And you can see that you've got the fluid sequences that's coming up bright. And again, you can see the changes within the bony edema here. There's your sacroiliac joint on the side, sacroiliac joint on the side. That's your sacrum. And then these are your iliac crests going out the side. Okay. So in an acute pelvic trauma, MRI isn't your first option to go with. So as I said, ultimately you're looking at a CT scan because in pelvic trauma, you've got to make some decisions pretty quickly about what you need to do, whether the person needs to go to theatre. And the other problem is with pelvic trauma, you've got a very big venous plexus that sits at the front of the sacrum called your Batson's plexus. And you can get a venous injury to this, which creates a bleed, and a person can lose a huge amount of blood through this. So you want to know what you're dealing with pretty quickly because you may need to go to theatre to either pack the pelvis or to embolize some of the bleeding to control it, because a person will die from the bleeding if it's not addressed. So in acute settings, you don't always have access to an MRI scan. If the patient has been very unstable, often we've got them in a pelvic binder. So the binder may not be MRI compatible, depending on which service you're using. And you don't want to take the binder off again in case of bleeding. There may be sometimes we put an X-fix on. So if the person's gone straight from ED, they've had a CT scan, they've gone up to theatre, they may have had something done, then we want to do a delayed MRI scan. If we've got a frame on the pelvis, which is pins into the pelvis to hold it steady, sometimes we get artifacts from that. So what we currently do now is we use ceramic pins and fiber carbon rods to make a frame to hold the pelvis, but not every unit has that equipment. So again, you've got to be sure that what you're using is MRI compatible. And then you can get a subacute phase as well, where your CT scan just isn't giving you the information. It's not correlating with what you're seeing clinically. So you then get an MRI scan to fill in some of the gaps. Again, I've put down the sequences that we get, so you can have a look at those and do a little bit of reading around that. So occult fractures is generally what we're looking for. So occult fractures is more along the lines of your insufficiency fractures. So this is where the person has a lot of pain. You suspect that they've got a fracture. You do an X-ray, you do a CT scan, nothing is showing itself. but just looking at the person, examining the person, you know that there's something going on. So a lot of this is related to osteoporosis, postmenopausal women particularly, and again, very common in the pubic rami, the sacral ala, and also into the acetabulum. So often it's a misdiagnosis. Often the person then has significantly reduced mobility, and a lot of the time they decondition because they're not mobile because they're not sure what's going on. And in some cases, you can end up with chronic pain syndromes as well. So again, we're looking at a combination of the fat weighted and the fluid weighted. The fat weighted because normally the marrow is nice and bright, so we're looking for dark areas on our fat saturation. On our fluid sensitive, we're looking for the bright areas, and particularly looking for cortical breaches. So again, one of our cases, we had a 78-year-old female who was post-fall. She was unable to weight bear. X-ray was normal, but the MRI stir actually showed up some bright signal in her pubic rami. So she was diagnosed with an occult fracture and managed with protected weight bearing. So we normally just give these people a frame or crutches, depending on what they're able to manage. And anytime you've got a fracture at the front in the pubic rami, you need to check the sacroiliac joints, because if you imagine breaking a ring, if you've got something that's a ring, it's very difficult to just break one part of the ring, and you often have a second break somewhere else. So you really need to be sure that if you do have an injury or bony disruption, that you don't have a second one that is a bit more subtle that you may be missing as well. So this is what showed up. This is the H sign. People talk about the Honda sign. It's a very classic sacral insufficiency fracture. It's normally an indication of an unstable segment. So often when we get people with this, we do need to take them to theatre and put some screws across to stabilize that. But if it's just on the one area, it's not necessarily the H, and that is just managed with protected weight bearing. So insufficiency fractures is just where you have normal stress, but the bone is weak. And that can be because of physiologically osteoporosis, or the person may be taking medications such as steroids or have had some radiotherapy. Often we get these orientated vertically in the sacrum, but you can get this horizontal component to it, and this is where we call the Honda sign. So this is it here. Imagine the H of the Honda is what we look at. So this is because we've got sacral marrow and edema. It shows up beautifully on your stir sequences. But again, in this particular age group, in this category, you need to be sure that you're not dealing with the metastases. So again, we're using contrast to make sure of that. We're taking their history. Do they have a history of malignancy? If it's a male, have we done a PSA? If it's a female, have we examined the breasts? Have we examined the thyroid? And normally some blood markers are good as well to see where we are from a baseline point of view. So as I said, on the sacrum, we get both longitudinal fractures and transverse fractures. Your MRI generally shows your marrow edema along the fracture. You can get an extension into the sacroiliac joint. So this is what I'm saying. Even if you get a pubic rami issue in the front, you need to be sure that you're not missing anything in the back. And if you've got something in the back, you need to be sure you're not missing anything in the front. You need to be sure that you've not got an associated soft tissue hematoma. So just make sure not only are you looking at the bony structures, the ligamentous structures, but also at the soft tissue as well, because there's a zone of injury. And again, just an example how you get this longitudinal fracture coming down in the sacrum shows up beautifully on your fluid weighted sequences. And then this is your transverse fracture. So again, there's your H sign. I've put that in again. Often you can see the transverse components on the sagittal side on your CT scan, and you can see that it's transected through there. A little more difficult here, but again, you can see that there's the pathology on the side with your CT scan. Okay, and then your iliac joint injury. So often if we've got an osteoporotic fracture, the fracture will extend or can extend into the sacroiliac joint, but you can have sacroiliac joint disruption with significant trauma. So anytime someone has a pelvic injury, low back injury, we do look at the sacroiliac joint. Some of the clues that you can get is if they've got disruption, if they've got fracture of the L5 transverse process, and if they've got disruption of the iliolumbar ligaments as well, that's normally an indication. But your transverse fracture L5, you do need to think, do you have an occult pelvic injury there? So your MRI is going to visualize your capsule, is going to look at your ligaments, not necessarily seen on the CT, and you want to be sure of the anterior posterior sacroiliac ligaments, because it gives you an indication of the nature of the injury. So this is the type of sacroiliac disruption that we get. I'm not going to ask you this classification, but I just want you to know that if you've got any trauma, you do need to look at the sacroiliac joints. If there's any widening or displacement, you do need to be aware of that. So clues like if you've got disruption of this pubic symphysis at the front, there's generally something going on at the back. If you've got something going on at the back, there's generally something going on the front. And not only do you have widening where the pelvis opens up, but you also get vertical shear and rotary shear as well. So this is where you've got a vertical component, a bit of a vertical component, but a more dramatic vertical component here. So not only is this opened up a bit like a book that opens, but you get a vertical component to it as well. So anytime you've got a vertical component to the injury, it takes it up to another level of severity. Okay, so again, primarily looking at your fat weighted and your fluid weighted for the same reasons as we've had previously. You need to look at the pelvis in a whole because you don't want to miss a sacral or an iliac wing fracture that we often see. And if you've got a diastasis on your pubic symphysis of more than 4 millimeters, it's an unstable injury. So again, that person needs to be seen by someone on the surgical team. And obviously, if you're faced with something like this, there's no doubt as to the seriousness of that injury. Okay. Again, some examples to show you. So this is the opening up. This is a sacroiliac joint injury. So this isn't, sorry, this is some disruption that's going through there with a fracture. And there's your sacroiliac joint on the other side. So you can see the disruption and the opening up here. Again, you can see the involvement here of the sacrum. This is the sacral ila, and then this is your sacroiliac joint here. So you can see the widening over there compared to the other side. So it's always good to look at the other side, so you know that is intact. That's the sort of gap that you should see, and you can see there's a very obvious difference, and there's comminution, which means this is fragmented. So there's lots of different fragments here through the sacral ila. So this is quite a nasty injury. And again, you can see the displacement through there. The sacroiliac joint at that level is still intact, but you can see that that's not good through there. Okay, pubic ramian acetabular fractures. Often you can see the edema on the bone. You can see little cortical breaks. Sometimes you don't see them on the CT scan, but again, you're looking for your signals on your fluid weighted in your on your MRI. You also want to look at the acetabulum because sometimes you can have stress fractures through there that just are not particularly clear on any other imaging, and particularly if they've had trauma fallen on their hips. So you're looking for edema in the surrounding muscles, you're looking for hemorrhage, and you're also looking for some tendon avulsions if you can see anything like that. So here I've put in the I've put in part of your hip. So here's your ala, there's your femoral neck, there's the acetabulum. This is coming down into the pubic ramus, and there's been a subtle fracture there on your pubic ramus. This is now an axial, so there's your femoral head, there's your greater trochanter, and this is the pubic rami going down, because you're now seeing this in axial view, and you can see with this fluid-weighted sequence, there's the pubic rami disruption. And then again here, you can see this is your femoral head, and you can see the disruption here on the pubic ramus. That shows up bright on your fluid sequences. Okay. So again, the story is exactly the same with everything else. You've got to see your MRI in context. So take a good history, do a really good examination. You want to then look at the areas of interest that you've identified clinically. You always want to think, if you don't have a very clear history of trauma, are you dealing with a metastases? Are you dealing with an infection? So the way you differentiate that out is by adding in your contrast, looking at your bloods, looking at the clinical picture, and again, revisiting the history. Have they been unwell? Do they have a history of cancer? You always want to look at the soft tissues, particularly if you've got neurological involvement, and you need to see this in context of what decision making you're going to do, what is the rehab going to look like, what is their weight bearing status going to be. So in summary, your MRI is best for looking at these very subtle occult fractures, generally insufficiency based. So again, you're looking at your fat weighted and your fluid weighted. You're looking at your sacroiliac joint ligamentous integrity and the sacral marrow patterns. And essentially, if you've got any unexplained pain, because sometimes the person may have been told, look, there's nothing we can find on the CT or the X-ray, you're good to go. MRI wasn't done, and you may have to come back if things aren't settling and revisit the injury.